Thank you for joining us for Conversations in Relapsed Refractory Multiple Myeloma. During this segment, we will be discussing bispecific antibodies in relapsed refractory multiple myeloma, focusing on the rationale and efficacy. I'm Dr. Usmani, the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center, and I'm joined by my wonderful colleagues, Dr. Jesus Berdeja and Dr. Joseph McHale. Over the years, we've all seen the wonderful progress of therapeutics in myeloma, many new classes moving from the relapse space into earlier lines of treatment. And more recently, we've had several now FDA approvals for bispecific antibodies. But even before jumping into some of that conversation, I want to get a sense of what your experience has been, dealing with myeloma patients over the years. There was a time when the overall survival outcome was measured in few years and we didn't have options. But now the disease is becoming more, chronic in nature and has more of a relapsing, remitting kind of a course. So what are your thoughts, Jesus?
Yeah, no, I think this is a very exciting time for myeloma. I think you're right. I still remember the days when we were excited about new therapies coming on with overall response rates of 30% and PFS in the 3 to 4 month range. And then along came CAR T cells, right, which kind of blew that out of the water. And the bispecifics are leading in that same direction. We've seen response rates, that are in the 60 to 90%, depending on what you're talking about, and quite durable. These are with single agents. So very exciting times, I think.
Joe, what do you think?
Yeah, no, I think you're absolutely correct. I think, back when I started in myeloma, and the two of you were probably in utero at the time, we really didn't have many options, and our patients basically lived 1 to 2 years. Now we have a significant fraction of patients that are going beyond a decade. And so more than ever is it important for us to use the right treatments sequentially and not burn bridges later with treatments that can adversely affect patients later. The only caveat I think I'd add to that, Saad, is that I'm humbled every day in clinic, which I suspect the two of you are as well, that there are still, albeit a smaller fraction and thankfully shrinking, but there is still a fraction of patients with that highest risk disease that just seem to burn through so many of these great options that we've historically had. And I really hope that some of these newer therapies will reduce that fraction even more, because you're right. Most patients get treated. They have their longest remission is their first one, and then it just gets shorter each time. I think we're starting to challenge that old way of thinking with some of these newer therapies.
And, just like, you mentioned, Joe, I think, we have come from a place where we had very few options and you would treat to get any response and then stop and wait for symptoms to recur, to now thinking about picking the best options that give our patients the best likelihood of going into a deep response, because that's what's translating into survival outcome benefits. And one theme that keeps on coming up is, do all of our patients get all the drugs, the wonderful drugs we have, and should we be saving the best drugs for later? And what are your thoughts around that? Because we've had a lot of wonderful work that Rafael Fonseca has done, looking at attrition of patients with each line of treatment.
Well, I'll jump into that and quote my typical line that you've heard me say before. Saving the best for last is great for a Hallmark romantic movie, but is not appropriate for myeloma. I mean, I think not only in drug development do we see drugs prove themselves as they come up earlier into the disease course, after they prove themselves in that heavy relapse patient, but because there is that natural attrition over time. You said Rafael's work, for example, thankfully the band gets wider, meaning we have a larger fraction of people that go to third, fourth, fifth line therapy, but there is still a narrowing of that line. So I think what we do in our first couple of lines of therapy, what I call the 1-2 punch, the first line therapy and second line therapy, even if we just for a moment thought of those two together, that may be more prognostic than almost anything else in the course of most patients' myeloma. So I do think it's really important that we not just say, oh, that's such a potent therapy, let's save it to the very end, because at the very end, the disease may not be able to be controlled.
Very well said, Joe. And Jesus, just staying with that theme, we used to, at a point, debate which mechanism of action to use first. Should it be IMiDs? Should it be PIs? And then, we went into, this phase of, all right, combining these leads to better survival outcomes, leads to better depth of response. But now, as we're entering this, era of immune therapies, we're getting more patients who may be double or triple class refractory. Jesus, can you just define for us what double and triple class refractory means, and what is the nature of the disease when the patients are relapsing? What are the outcomes that we would expect for them if we did not have any options?
Yeah, no, I thought thank you for that question, because I think it is important. I think in myeloma, I think we've sort of we're currently at a state where we're talking about sort of the traditional myeloma therapies and then sort of the new immunotherapies. And so when we talk about triple class, we're talking about the IMiDs, the PIs, the proteasome inhibitors, and the anti-CD38 antibodies. And so there is clear data now that in patients who have progressed through those three classes, that the outcomes are actually quite poor. We have real-world data that shows, and some study data that shows that basically these patients have a very poor response, and it's really what we were seeing in the past with response rates to their next line of therapy of about 30%, and progression-free survivals of only 3 to 4%, and overall survivals of really just a year. So if we step back and look at that, we're talking about potentially patients who have used these drugs in just 1 or 2 lines, as Joe said, because those are our current big punches. So clearly an unmet need for that population. But having said that, I think that is why there's so much excitement about these newer therapies, because that exactly is where these therapies have been tested and are looking quite impressive.
And one thing that we've started to talk about more, I guess, with the improving survivorship in myeloma. And Joe, you mentioned, many more patients getting to 10, 15, even 20 plus years of survivorship now. It's the quality of life metrics and all the supportive care measures that we need to incorporate into the care. What are your thoughts around that, Joe?
Yeah, I say it all the time. I don't treat myeloma. I treat people, right? And now that people are living longer, we want them to live better, right? And I think that's been the rationale for being able to engage the immune system, to use therapies that are less toxic, that allow our patients to have the convenience and the life that we want. And so it's incumbent on us, not only in these large trials, to capture quality of life metrics, but this has to be something that I discuss with my patient every day in clinic. Now that I have choices, even within these classes, within the bispecifics, within the CAR-Ts, within, that we want to match that to what's best for the patient. So I think that is absolutely fundamental in what we do. And I would take it even a step further. It's quality of life, but also their preference. Our patients are learning more about this than ever. And now that there is choice, we want to engage them in that shared decision-making model approach so that their preferences are seen.
Oh, thank you, Joe. Jesus, you've led the CAR T cell therapy revolution. I still remember the ASH meeting where you were on the podium presenting for the first time the ide-cel data, and all of us had our jaws drop looking at the overall response rate you were reporting. It was more than twice what we had expected with any of the other small molecules and therapies we had at that time. And then after the approval, we had some challenges. So can you tell us a little bit about your early experience with CAR T cell therapy, especially after the regulatory approvals and some of the lingering, logistic issues that we still continue to have?
Yeah, no, thank you, Saad. It seems like a lifetime ago, doesn't it? That when that first data was coming out, but it really hasn't been that long, right? It's only been about six years or so, maybe 7. So, but yes, I think autologous CAR T cells are amazing therapies that are translating to significant benefit for our patients. But let's face it, they're a pain in the butt to get, right? I mean, they're incredibly difficult to the logistics of them are so complicated. Not only do patients have to progress, and then they have to collect their T cells, assuming we have a spot. And then we have to wait for the manufacturing of the CAR T cells, which currently takes about 4 to 6 weeks, which means that person's myeloma cannot be exploding. They cannot be progressing because then they may become ineligible to actually see their CAR Ts. And so I think eventually, the patient that does get it, we do see significant benefit. But unfortunately, what we're seeing in the real world is that percentage of patients that actually gets to CAR T is actually quite small. So that is improving with time, and I think will continue to improve. But I think that is sort of the biggest benefit of having off-the-shelf therapy, like a bispecific antibody.
I think we're very well said. And, that's, you're right. That's the very advantage of bispecific antibodies. And this is something that we all observed in early clinical trials as well. Patients who wanted to get it, we wanted CAR T cell therapy, for them, we couldn't enroll because of where the disease was. And, you just had to pick the best, available option. And you went with the bispecific antibodies in studies. And that's perhaps what we're still doing in our clinical practices. Now that we have 3 bispecific antibodies that are approved. I had the privilege of being involved in the early development of teclistamab, and that was FDA approved back in October of 2022. But in less than a year after that, we had our second BCMA-directed bispecific, elranatamab, get its FDA approval, and shortly thereafter, talquetamab, which is our first GPRC5D-directed bispecific antibody. So, Joe, as these bispecific approvals come in, what was your experience with that long wait list that we had of patients on waiting for CAR T cell therapies and being in that triple class refractory situation where you're just trying to get them to just hang out for another few weeks or so they could potentially get the CAR T cell therapy. What do you?
Yeah, it was a challenging time, and thankfully now with more access to the bispecifics, I think it is allowed us, and Jesus made comment the fact that we have thankfully shorter wait lists than we did before, but now it gives us that option and that flexibility, and saying that for many of those patients who geographically it's difficult to get a CAR T, or who maybe have a rapidly growing disease, patients who would prefer not to go through a CAR T cell therapy, where we may have concerns about the ability to do the pheresis and to wait the 8 weeks, and we may not have a good bridge in the interim, we can get them quickly onto one of these 3 products that you described, teclistamab, elranatamab, and talquetamab. And it's been very gratifying to have those available to us, obviously, because we know that they've been very effective in that heavily relapsed space.
Now, the efficacy for teclistamab and elranatamab, appears to be, somewhat similar since they're targeting BCMA. But Jesus, do you see any differences in their safety profiles at all in your clinical practice, or can you glean that from the Majestic-1 and the Magnetism-3 trial data?
I would like to tell you yes, but the truth is they're actually very similar. And in terms of sort of the antibodies themselves are very similar, and the rates of cytokine release are very similar. The main thing that really differs is, at least in my opinion, is sort of the numbers of steps and the step-up dosing that's required for each of the different antibodies, with elranatamab having less steps. Initially, when they were approved, there was that benefit that elranatamab, if you had a PR or better, you could go to every other week dosing from weekly sub-Q dosing, but now that's also the case for teclistamab. And so, at least in my opinion, and I've used both of them, I think they're very similar. And I think it's sort of kind of the choice of which one is going to come down to the individual center in terms of the availability and the ease, and as unfortunately goes to the contracting that happens in terms of sort of how which one may get selected. But at least in my experience, they've been very similar, both outstanding, I have to say.
No, I mean, the more choices we have, the merrier. I think, it creates for a better, market as well, and hopefully, the we don't talk a lot about, accessibility and drug, cost of care, etc. But I think that hopefully will come into play and be, better for our patients in the long run. Joe, how has the experience with talquetamab been? What are your thoughts about the Monumental One data, as well as, the safety, unique safety, signals that we see with that particular bispecific?
Yeah, I mean, it's actually remarkable from an efficacy standpoint. For many years, we were stuck in that sort of 25 to 30% response rate. And yes, CAR T may exceed 80 or even 90%, but all of these bispecifics seem to be in roughly that 2/3. We may saw a little bit higher with talquetamab, into the 70% range. And I think that's what we're seeing in clinical practice. The difference here is, although the T cells are still engaged, as you noted, there's a different target, and that GPRC5D target has resulted in a different safety spectrum. There's still, the issues of cytokine release syndrome and potentially neurotoxicity. I think we're seeing a little bit less infections with talquetamab than we may have seen with the BCMA-directed ones, although we're getting better at managing them across the board, I think, with IVIG and dose reduction and the appropriate prophylaxis. But there are those GPRC5D specific toxicities, the effect on the taste, the hair, the skin, the nails. A lot of our patients are losing their nails. It tends to come back. And I think we're still struggling a little bit as to how to manage them, but every drug goes through an evolution, and I think we'll get better at managing them. But it's still very gratifying to say to a patient that I expect, the majority of our patients will respond to any of these three drugs.
Great. Thank you so much, Joe. So what I heard from both of you is that we've come a long way in improving survival outcomes for myeloma patients, where patients are living for 10, 15, even 20 plus years. However, we do have a group of patients who become refractory to the, three classes of drugs, the three classical, drug classes, the proteosome inhibitors, immunomodulatory drugs, and now anti-CD38 monoclonal antibodies. And, we need more options for them. And CAR T cell therapies, have demonstrated, excellent responses, but there are logistic limitations where you do need off-the-shelf options such as bispecific antibodies. And the three, bispecific antibodies we have high level of activity. The BCMA-directed ones have a different safety signal where there might be some infection risk. With talquetamab, it's more, the skin, the taste, and nail changes kind of side effects, in addition to the CRS and the neurologic side effects that may happen with any of these three products. Exciting times indeed. Thank you again for joining us for this segment on bispecific antibodies and relapsed refractory multiple myeloma, Rationale and Efficacy. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access downloadable slides, as well as other topic segments and case scenarios.